Alright, so last time we finished up GIT, now we're basically up to hematology and oncology, which really is two different chapters. In CK, it's pretty well combined into just one chapter though, and they also have transplant medicine as part of this chapter in the CK. So other than that though, just the difference of topics. There's nothing new here though. No brand new topics, no brand new type of blood cancer or anything like that. So you're gonna see all the same issues here as well. But before we delve into any of that, it's really important to make sure that we get down the main different concepts that we needed to know when we first started in step one, right? So first thing we had here was your hemostasis topic, right? Where you have your primary hemostasis and the coagulation kinin pathways, right? So those were pretty intense topics when we were brand new to all of this. So with your primary hemostasis, it was all about the first few steps of things that occur when you have some kind of bleeding, right? So you can imagine like a basic cut, for example. So you see you get your injury, endothelial damage leading to transient vasoconstriction via neural stimulation reflex and endothelin, which is just released from the damaged cell. And so this vasoconstriction will prevent bleeding from wherever the damage was. Exposure, so von Willebrand factor binds to the exposed collagen, and then the von Willebrand factor is from weevil pallid bodies of endothelial cells and the alpha granules of platelets. These specific topics were things you really had to memorize for step one. You won't necessarily get these specific little technical things as a question in CK, but it's still stuff you do have to make sure you know. Right, so you find von Willebrand factor in weevil pallid bodies, and you find von Willebrand factor in the alpha granules of platelets. Right? So weevil pallid bodies. Weevil pallid bodies are going to be an answer choice you want to make sure you know about, not get confused when you see that. That leads to then adhesion. Platelets will bind von Willebrand factor using GP1B receptors at the site of injury only. Platelets undergo conformational change. Platelets are able to then release ADP and calcium, which actually will be necessary for your coagulation cascade. So we'll see in the coagulation cascade there's a step where a lot of calcium is required. ADP itself, though, helps platelets adhere to the endothelium. Right, so this was GP1B. 1B only has one job. It's to connect, as you can see in this image right here at the bottom. Right, GP1B is that red receptor that's on this big platelet. It has one job, is just to connect to VON, which you could pronounce as 1, von Willebrand factor. Right? So of course in anyone who has von Willebrand disease, where they don't have von Willebrand factor, they won't have this primary hemostasis. It's not going to work too well. Right? Activation. ADP binding to the P2Y12 receptor induces GP2B3A expression on the platelet surface as well. That actually has a job of connecting two platelets to each other. Right? So that's how the numbers are going to help you. Right? GP1B has one job. It connects to one Willebrand factor or von Willebrand factor. GP2B is the one that connects two platelets to each other. Right? Fibrinogen binds GP2B3A receptors and links platelets, as you can see right here with the blue receptor. And so you need your green fibrinogen, which is actually something you'll find within platelets. Okay. Right here you can also see that in the vascular endothelial cells, your blood vessels basically, have von Willebrand factor inside of them. Okay. So these were little things that were pretty critical back in step one. And then there was the topic of ristocetin, right, where you can do a ristocetin assay to see what's happening. So here I wrote the common diseases. You have Bernard-Soulier, where you have a lack of the GP1B receptor, this red receptor. That lack of GP1B is very similar to von Willebrand factor disease, where you're just missing the purple von Willebrand factor. So if you're missing either one of those two things, either the red receptor, GP1B, or the purple von Willebrand factor, if you're missing either one of those two things, they're both going to present the same way. You won't be able to do this first thing, which is the first few steps of primary hemostasis. When you do the ristocetin assay, ristocetin actually fails in both of the above diseases. There will be a negative agglutination test. So what does the ristocetin assay? Well, ristocetin actually activates Waldenburg factor to bind GP1B. So you see it's revolving around the same two guys. Right? The same two guys are involved once again. So if your Waldenburg factor or GP1B are missing, giving ristocetin won't activate this connection. Right? If the problem is anything else, then you give them ristocetin, this connection will still happen. Right, so that's basically it for that. The last disease is this Glanzmann thrombocythemia, which is actually a lack of the blue receptor, GP2B3A, where platelets just are unable to connect to each other. And so that's also not so good, because then again you cannot connect a bunch of platelets and then you can't make a good primary hemostatic mesh, right, the fibrin mesh that you're trying to make. So after that, generally speaking, you have your coagulation and kinin pathways, where if you look for where do you need calcium, what this asterisk tells you all the steps you need calcium in, which is basically everything revolving around this central area. Right, so you need it for your entire extrinsic pathway, which is very tiny. It's really just one step. You need it for the last step of the intrinsic pathway, and then you need it for the initiation of the common pathway. So that calcium that you need, that you see right here with the orange asterisks all over, actually came from this step, right? Release calcium. Right? Platelets release ADP and calcium necessary for the coagulation cascade. The ADP itself was used right here. Right? So ADP gets used up right here in itself, doing its own thing, connecting things and whatnot. As you see right here, you have your ADP receptor. Right? When ADP connects here, you actually send out more of these blue receptors, GP2B3A. Right? So where does the ADP come from? From itself. Platelets release ADP from themselves, which actually, so imagine ADP will come out and then attach to its own receptor out here, telling the platelet to put more of these blue GP2B3A receptors outside, allowing two platelets to connect to each other. So this is like, an entire story of how this works, and you have to be able to talk about it without the book in front of you. You have to be able to understand it, comprehend it, know it very flawlessly so that you can break it down in a question. And when you're reading a question and they give you some kind of problem in the question, you should be able to figure out exactly where the problem must be. Now coming here to the coagulation pathway, the Roman numerals are all here to explain which pathway goes where. So the easiest thing, of course, is the extrinsic, right, where you just have number 7. It becomes activated with calcium to 7A. 7A then combines with tissue factor, which comes from damage of the outside area, right, and damage to the extrinsic tissue. And then that combination will go ahead and allow 7A to activate factor 10 to 10A. So activation of factor 10 into 10A is the very first step of turning on the combined pathway, or the common final pathway. And the combined pathway is the more important one. The other two are just things that can tell the combined pathway to turn on, but the combined pathway is the one that actually leads to formation of a fibrin mesh that stabilizes the platelet plug. So right here you are making the platelet plug. This is just formation of a platelet plug. When you do the coagulation and kinin pathways, mainly the coagulation pathway, you'll stabilize that platelet plug with fibrin mesh. So that was just the extrinsic, very easy, just 7. Nothing else is involved. So if you're doing any kind of patient work, you have to be able to figure out which coagulation factor might be missing. And so you're going to have different tests to do. So here I wrote for the extrinsic path, right? It starts at factor 7, which is activated by thromboplastin, tissue factor, and that becomes 7A, which activates factor 10 to become 10A, which is part of the common pathway. This is an important path for clot initiation. We measure its function by following PT, prothrombin time. Right? PT for 7. By adding tissue factor to activate factor 7 and see if it works. The other test is the INR, which is managed mainly by just warfarin. PT checks factor 7 as well as the common pathways. Everything checks the common pathway, but the difference is going to be intrinsic or extrinsic. So the PT is for your extrinsic pathway, which is very easy to remember if you just think of the word PET. Right? That's all it really is. PET. So E for extrinsic, PT. Okay. Then you have your intrinsics, this one right here, right, which is contact activation pathway. So you have collagen, some basement membrane, or activated platelets. Any of those things can actually take factor 12 and activate it. That then leads to a cascade, as you can see, as a domino effect. 12 becomes activated, then 11 becomes activated. Then you have 9 here, which becomes activated. And then some funky stuff is happening here. You can see you have 8A that came from von Willebrand factors. A very critical thing to watch out for. Your von Willebrand factor carries factor 8 with it. Right? It's a protector of factor 8, which is why it's very rare for someone to run out of factor 8. This is something you want to keep in mind, because you might get a stupid question where it really looks like the patient should be missing factor 8 or some other factor. And if they have functional von Willebrand factor, then they should have factor 8, so you would pick the other thing. Right? At the same time, if they don't have any von Willebrand factor, then it's very easy to just assume they're probably lacking factor 8 as well. Before this contact pathway to activate, you can see it's much more intricate than your intrinsic pathway, which was super easy. So here, before, even though the damage to any one of these things was already activating everything up to factor 9, factor 9 needed a cofactor, which is factor 8, to help it go turn on the combined pathway regarding factor 10. Right? And all of this needs calcium. Okay, so if someone missing von Willebrand factor, such as in von Willebrand factor disease, will have difficulty doing this intrinsic pathway. Right? And then at the bottom here I wrote intrinsic pathway starts at factor 12, which is activated when it's exposed to collagen, basement membrane, or platelets, regardless of whichever type of injury it might be, as well as or HMWK, which you can see up here. Right? High molecular weight kininogen, which can also go ahead and activate this. And so this is a separate cascade, so we'll come back to what's happening here separately. That's a whole different set of things. Then we get 11 to 11A, 9 to 9A, and then 9A works with the cofactor 8A. The factors 9 and 8 lead to our common pathway factor 10. This is best monitored by PTT. PTT, which is initiated by phospholipids, and an activator substance that tricks factor 12 to be activated. This is how you actually do your PTT test within the lab. Right? So if they're ever trying to explain to you some kind of thing they're doing, but they don't want to call it PTT, they'll tell you that they took the blood, they added some phospholipids, and then they activated an activator substance, whatever it might be. They might actually name a specific type of substance. And then you're going to see, whether or not factor 12 activated, which should lead to an entire cascade of 11 and 9 and 8, all activating to finally activate factor 10. PTT checks the intrinsic and common pathway, right? So this right here, this is PT. Right here, this one is PTT, right? So that one is usually just remembered with PITT, PIT. Right? Which of course is easy to remember simply because you can't really think of a word that would be P-E-T-T. That doesn't really spell a real word. Neither does this really, but PIT sounds a little better than saying this. Right? PIT is also just one T, but it does the job to spell it out like that. There are other mnemonics for memorizing this too, which by the time you get to CK you probably won't need. When you're new to these things, it helps to have these mnemonics, but you won't really need it anymore. There's another thing that you have to keep in mind, which is that warfarin affects PT, right? And heparin affects PTT. So when you combine all this knowledge to make a mnemonic, you actually just put the you put the W into this, and you can write wept, right? Which is like the past tense of crying. Wept. Warfarin, extrinsic, PT. They go together. And then here, when you put a URL into a browser. It has HTTP in it. So that's what you see here. All right, so it's just going to be your HTTP. The TTP is backwards of PTT, heparin, and intrinsic. They all go together. So someone who's taking heparin will have a prolonged PTT, and heparin affects the intrinsic pathway. Someone who's taking warfarin will have a prolonged PT, and warfarin affects the extrinsic pathway. And so these are ways you memorize this and understand it, and then these are ways you actually evaluate patients. Maybe you don't know if they actually take warfarin or not, so you would check for these numbers and see if anything like this is actually changed in them. As far as the common pathway is involved, you can see pretty straightforward. The same cascade of things keeps going, but the numbers are very different now. So 10 actually just jumps straight to 2. Right? Factor 2 is very critical. This is your prothrombin, which becomes thrombin. Right? And to get to here, you need another cofactor. So the cofactors are in green, as you can see, right, which is factor 5. Right? This is another cofactor right here that you really need help from. And without factor 5, you would have a messed up combined pathway. You would have difficulty going from 10 to 2. Right? So 10A activates 2, 2 becomes 2A, 2A then activates number 1, which is also very critical, fibrinogen, which becomes fibrin. And this is the ultimate key player because fibrin will just aggregate with itself. And then you can see right here, number 13, which is the final player. The 13 will further add on to the fibrin mesh, and you create this net, which is basically like putting Band-Aid on your bleeding, but naturally. All right. So all these numbers are not something you're just going to remember the first time you study this. Right? In step 1, you were supposed to already have this memorized and mastered, and then when you get to CK, it should be something you can naturally just write out, like in this format. You should just be able to write it all out very simply, very straightforward. And you see you have your 13, 5, and 8, which are special guys that are helping out in different places. Okay, so right here I wrote common path starts with 10 to 10A. 10A requires 5A. They activate 2 to 2A, which is prothrombin becoming thrombin. And then thrombin breaks fibrinogen to fibrin monomers, which is 1 becoming 1A. Thrombin also activates 5, 8, 9, and 13. As you can see right here, right, you can see they have this arrow where thrombin is activating 13, and you have this arrow which goes to here, here, and here. Right, so thrombin is the very critical guy, number 2A, that activates all these other guys that are supposedly acting like little cofactors. So that's pretty cool because, you know, what that's telling you is that if you activated the combined pathway, your combined pathway further upregulates your intrinsic pathway as well as the combined pathway itself. And so if some emergency pathway has been activated, it'll make sure it further upregulates that same emergency pathway. In addition, if your extrinsic pathway comes here and activates all of this, then thrombin will once again also activate intrinsic stuff. So even the extrinsic pathway can indirectly turn on the intrinsic pathway, and that's a very hard level question that you can get. And with most med students, when I tutored them this topic, I asked them, like, do you know any way where the extrinsic pathway can cause activation of things in the intrinsic pathway? And almost no student I've ever asked that question to ever knew that. And so you see those arrows here, it is in the book. Of course, it's not explicitly written the way I'm mentioning it, but it's a thing. It's clearly a thing. So when your extrinsic pathway 7 activates 10, and 10 activates 2, the 2A will activate the intrinsic pathway, starting from right here, and it'll further upregulate its own activity, right here and right here. Right? It actually immediately activates 5A to make more 2A. And so all of that stuff is basically positive reinforcement of making sure that this bleeding is stopped. Right, so those are all the key steps that you need to know for your entire coagulation cascade. The last thing is your proteins C and S. Proteins C and S, you can think of them as cut and stop. Right? Proteins C and S stop the cofactors 5A and 8A. thereby acting like anticoagulation. They stop all of this cascade. So if for any reason you have a deficiency of protein C and S, you become hypercoagulable because you can't stop your coagulation cascade. This is actually discussed in the book as well. It's taught in step 1, protein C deficiency. Now, when you look at warfarin, right, warfarin does a lot of things to a person. It's a very important high-yield medication that we have to take. There are people out there who are taking warfarin every day. So when I did my hematology and oncology rotation, I used to have to create calendars, monthly calendars for people, where it was a very simple calendar. On the entire calendar, I would write out how much of warfarin to take every single day. And it was basically the same dose every single day, but I think there was one day of every week that was a little bit of a higher dose, and then the rest of the day was the same. Every single patient had a different dosage calendar, and they needed to take that calendar home with themselves so they don't fuck up. Because if you mess up and you take the same warfarin twice that same day, you really mess up this entire cascade, right? You need to maintain INR in a very therapeutic range. To maintain INR in these patients, we would try to keep it to between 2 to 3. That was always the goal with all the patients who were on warfarin anticoagulation. But you don't want to anticoagulate too heavily, nor do you want to miss the anticoagulation and become hypercoagulable. Right? So people who take warfarin regularly have this, whatever condition they have this inherent threat that they're going to hypercoagulate, leading to thrombosis or something. So those calendars were very critical for them, because as soon as they would take the warfarin, it was like they had to religiously write on the calendar that they took it for the day. They took it for the day, not to confuse it and take it double or forget to take it, stuff like that. It'll just throw off their INR for the whole week. And as soon as they were done for that month, they would come back for the next set, right? And they can't prolong that appointment. They can't mess up that appointment. They have to come either earlier or right on the day of. Now here you see warfarin in action, but there's one other thing. There's liver failure, which we just talked about, right? We just finished GIT. So that's why I always tell everyone that, even though step 1 first aid in any CK as well, first aid is an ABCD order, yeah, but it's actually perfect in that ABCD order, because since we just discussed liver failure, we already know that yes, if you have liver failure, people would have a synthetic dysfunction where they lack the ability to synthesize all of these coagulation factors. And warfarin also stops it. Warfarin inhibits epoxide reductase, which is actually supposed to take inactive vitamin K and reduce it to make active vitamin K. The active vitamin K is then going to activate GG carboxylase, gamma glutamyl carboxylase. Gamma glutamyl carboxylase will then take all your inactive 2, 7, 9, 10 CS. You have to remember those numbers. They're perfectly great together, and those are the numbers you have to just be able to repeat perfectly off the back of your mind. 2, 7, 9, and 10. Those all require potassium. But without potassium, due to warfarin or due to liver failure, without potassium, you're not going to be able to activate them because GG carboxylase will not work. But if everything is fine, then of course you were able to activate it. And you see, it also has the C and the S. Everything needs to activate together. These guys, 2, 7, 9, and 10, are coagulants. They actually turn on clotting factors, and you make more fibrin to make your little fibrin mesh and stop the bleeding. C and S are anticoagulants. They cut and stop these coagulation factors. So on the next page you see that, right? You have your thrombin, you have your antithrombin pathway, and you have your protein C pathway. The antithrombin pathway works with heparin-like molecules which enhance antithrombin 3 activity. This thing here is antithrombin 3. What did it do? It took your thrombin and killed it. So thrombin, remember, was this guy right here. Remember, these guys have names. Thrombin was factor 2. Right? Fibrin is factor 1. Right? So you have to remember these names are for the activated guys, thrombin and fibrin. The longer names are for the inactive guys. Thrombin is the activated 2A, fibrin is the activated 1A. So thrombin can be destroyed either by antithrombin, because you have heparin, or some heparin-like molecule that activates antithrombin 3 and kills it, or thrombin can be degraded by protein C. So that's what they're showing you here. Right? Protein C is killing the triangular thrombin. Thrombin, thrombomodulin complex in the endothelial cells protein C becomes activated protein C, requires protein S, and cleaves only factors 5 and 8, which were critical because those were the cofactors. If you kill the cofactors, you'll basically stop this entire pathway right here, and you'll stop this connection right here, so you won't be doing any of this anymore. Right? You'll severely slow it down, if anything, at first, and then it will stop by itself. Now, there's a problem with all of this because this is what you get questions on. Patients that take warfarin, right, will often first kill something else and then lead to hypercoagulation. So let me see where I talk about it. This is just a question teaching you that GG carboxylase is responsible, and then, okay, that's it. So here we have this thing I wrote right here, right? Protein C has a shorter half-life than 7. So protein C, in effect, is the shortest half-life of all of these guys, okay? Step 1 is too long, is the mnemonic to remind you that 2, factor 2, which is your prothrombin, factor 2 has the longest half-life. So step 1 is too long, to remind you that factor 2 has the longest half-life. And the Snow White has 7 dwarfs, which are short, so 7 has the shortest half-life. But protein C has an even shorter half-life than factor 7. Now think about this. Warfarin was supposed to stop all of these guys from working. However, unfortunately, warfarin doesn't stop all of them from working at the same time. First, warfarin will actually end up killing C. And because it has such a short half-life anyway, any C that's around, warfarin will just immediately kill. And then factor 2 has the longest half-life, so even then you'll probably kill this, kill this, kill this, and then S is already now working if C isn't working. Because remember, they're sequential. First C has to do its thing, then protein S does its thing. So when you killed C, you killed S also. Now notice the imbalance you get. Because you still haven't killed factor 2. You just started taking warfarin, and you still haven't killed factor 2 though. So you get this imbalance where you lost your anticoagulants, but you retained your clotting factors. Right? You lost your anticoagulants, but you retained your clotting factors. So this leads to hypercoagulation. And then you get the side effects you see in people who take warfarin without doing a heparin bridge. So we jump over to the pharmacology that we'll need to know because there's no pharm section in CK. Right, so one of the crazy things you will most likely actually see when you start, your residency, or maybe even in your oncology research not research rotation, is this heparin-induced. Sorry, the heparin-induced thrombocytopenia is different, but the warfarin-induced bleeding, right? The hypercoagulation, initial risk of hypercoagulation. Right when you start warfarin, there's a risk that you can get hypercoagulation because protein C has a shorter half-life than factors 2 and 10. Existing protein C runs out before the existing factors 2 and 10 deplete, and before warfarin can reduce factors 2 and 10 production. So you end up having too much factor 2 and 10, but not enough of the anticoagulating factors protein C, so you get hypocoagulation. You get skin and tissue necrosis within the first few days of large doses, believed to be due to small vessel microthrombosis. So you need to immediately reverse this, but there's a tricky answer to that. So most people will fall for the answer choice of picking vitamin K. But giving vitamin K will not cause immediate or rapid reversal. Vitamin K will just go to the liver, and then your liver will now be able to make more of the factors. But all of that synthesis is going to take time, right? So for rapid reversal, you have to actually give them the factors they lost, either as fresh frozen plasma or PCC. And one of the ways to avoid this hypercoagulation is to do a heparin bridge, which means to start heparin and then bridge them over to warfarin. See, heparin frequently used when starting warfarin. Heparin's activation of antithrombin enables anticoagulation during the initial transient hypocoagulable state caused by warfarin. Initial heparin therapy reduces risk of recurrent venous thromboembolism and reduces the skin and tissue necrosis. So if we go back to where we were just now, and we just saw this right here. So because warfarin stopped this, you can use heparin to turn on this, which will still kill your triangle, the thrombin. Right? So you need to start a person on heparin first to make up for the lack of protein C that you're going to see in the patient when you start them on warfarin. Very important concepts to have down. Right? That's basically all your hematology in a nutshell. The rest of hematology, as far as questions are concerned, are going to heavily rely on your various anemias. This page, right? All the different anemias you can get. And to master all your anemias, you're also going to need to master your iron panel, right? And the understanding of hepcidin and your transferrin iron saturation, transferrin or total iron binding capacity, TIBC, and what all these guys are supposed to do, how it all works, etc., etc. So we're going to talk about that as we dive into looking at your various types of anemias. So now we can jump to here, where the first thing they talk about is your coagulation disorders. So this should be a fairly easy conversation now that we've just reviewed how all the coagulation things work, and we had a slight conversation of heparin versus warfarin. I forgot one thing, just heparin. So we didn't talk about heparin. We talked about warfarin. Let's look at heparin too, right? So there's heparin. Heparin is very high yield question regarding HIT, heparin-induced thrombocytopenia. What does heparin do? It just activates that antithrombin thing, which kills thrombin, factor 2A. Right? It also kills factor 10A, but we never really talk about that too much, which is kind of dangerous because you can get a question where 2A might not be an answer choice, then you pick 10A as the answer choice. Heparin has a short half-life, but it does its job in the short half-life. What do you use it for? Immediate anticoagulation in anyone who has a pulmonary embolism, acute coronary syndrome, an MI, DVTs. It's also used during pregnancy because it can't cross the placenta. And as we discussed with our HTTP mnemonic, just remember the I, HTTP. The I can be for internet, right? I, HTTP, to remind you of intrinsic, heparin, PTT. Right? Adverse effects is this one right here that we really care about. HIT. The other adverse effects, of course, this can really happen with any anticoagulation you take, but the HIT is the real issue, right? Any anticoagulation you take can cause bleeding. That's not really a very major side effect. But either way, if someone has these side effects, you need to rapidly reverse this too. So for rapid reversal here, the antidote to heparin issues is protamine sulfate, which is a positively charged molecule that actually binds all the negatively charged heparin and turns it off. Heparin won't work anymore. So heparin-induced thrombocytopenia is a development of antibodies against heparin-bound platelet factor 4. So heparin is supposed to bind platelet factor 4. But if your body finds that complex of heparin and platelet factor 4 as something weird, you might make antibodies against it. The antibody heparin PF4 complex actually activates more platelets, which leads to the thrombosis and thrombocytopenia. The highest risk is with unfractionated heparin, which is big heparin. Right, so unfractionated heparin is this longer chain you're seeing on over here, unfractionated heparin. And then you can have low molecular weight heparin, which is smaller, because that's why they call it a low molecular weight. It's smaller, so it's lighter. Both of them work initially by actually binding antithrombin. And when they bind antithrombin usually is bound to factor 10A. Right, so it looks like this. And what the unfractionated heparin can do is make this nice ternary complex, which you have to remember in questions. If they tell you this complex is being formed, then they're using long unfractionated general heparin. Okay, it's only this one that can bind like this. The other one can't. The other one cannot come around because it's too short. This is your low molecular weight low molecular weight heparin, and it just binds to the same exact complex, but it doesn't spin around it like that. It doesn't lock it in. Right. So what's happening? Well, you want to see the fact that, here with unfractionated heparin, it was able to bind factor 10A and 2. Right? There's two different complexes you're seeing here, right? Either factor 10A or 2. LMWH really only binds factor 10A, not the 2. Okay, so let's keep that in mind as well. Tiny difference, but that tiny difference is all you need to get a question wrong. Here they tell you about the low molecular weight guy. It actually acts predominantly only on factor 10. Like we see in our picture. It only acts on factor 10, the orange triangle. But the purple triangle here is actually acted on, which is your factor 2A, thrombin, is only acted on by unfractionated heparin, which is what you would have to give to someone as a heparin bridge, right? Low molecular weight heparin acts on factor 10A. Fendaparin Nux actually only acts on factor 10A. Some LMWHs will have some effect on factor 2A as well, but it's really not that significant because remember, factor 2A has the longest half-life anyway. So if your medication doesn't have major effect on factor 2, it's not going to be a noticeable effect. And then that's basically it for all that. Okay, perfect. Right. So when someone gets HIT issues, it looks like this. Right. So what you're seeing here is you have the IgG, this purple thing, this IgG antibody, which is now going to attack the heparin that is bound to platelet factor 4. You see, made an immune complex, comes back, platelets. Now, what are you going to have? So when all this activation from the antibodies occurs, the first thing that happens is platelets are going to be removed by the spleen, leading to thrombocytopenia. That's issue number 1. Then the other issue you're going to have is platelet activation, which will cause more platelet release and platelet aggregation. And of course, this is also going to cause you to run out of platelets because all your platelets are aggregating, and you're going to get thrombosis from the aggregation, issue number 2. So when something like this happens, you give them the protamine sulfate, and then you make note of it on their profile, right, in the EMR, so that you never give them heparin again. Right. So once you can't give somebody heparin, you could try other things like direct thrombin inhibitors, possibly warfarin, or other factor inhibitors like this one. Right. So there's direct factor 10 inhibitors and direct factor 2 inhibitors, which you can use if heparin is going to cause HIT. So let's start here now with our CK stuff. We're going to be looking at normal hemostasis, which we just reviewed, hemophilia, which you can have A, B, or C, von Willebrand disease, hypercoagulable states, DIC, TTP, and ITP. Keep in mind that von Willebrand disease is actually autosomal, I think autosomal recessive. Let me check that real quick. I just remember it's autosomal though. It's definitely not X-linked. And let's find where all that is here too, so we can always come back. Okay, this thing is autosomal dominant. Okay, von Willebrand disease is autosomal dominant, whereas your hemophilias are all mainly the A and B are X-linked. C is autosomal recessive, but this barely ever gets tested, so forget about C. But A and B are both X-linked recessive. So why this is significant is because X-linked stuff, whether it's recessive or dominant, doesn't matter, because for men, as soon as they have one X that has the problem, they have the symptoms. X-linked recessive matters in women, sure, because there's 2 X chromosomes, so the other X might be okay, so they won't get the disease. But what happens on STEP is that usually all hemophilia questions are going to be about men. It's going to be men or boys that are going to have hemophilia. And all your von Willebrand disease questions are going to be about women. Even though an autosomal dominant disease can of course occur pretty equally as likely in a male, just for STEP purposes, they do this. And this is something you see in UWorld as well. Almost any question you'll ever read about hemophilia, this guy here has what looks like bleeding by mimicking blah blah. Yeah, he has hemophilia, so of course it's a guy. The question is about a guy, he has hemophilia. And then this is just a summary thing we'll come back to. More of these questions right here. So this was different stuff. Okay, impaired cleavage of von Willebrand factor. Anytime it's a VWF disease, it's a woman. Right, hemolytic anemia, ITP. Even here, this question, which is about von Willebrand disease, is once again a woman, even though it could be a man. But then it becomes difficult to figure it out, right? So they use this gender difference thing to really help you pick as an answer choice. So if it is a male with a bleeding issue, and everything's adding up to really sound like hemophilia, it is definitely hemophilia. But if it's a woman with a bleeding issue, and it looks like hemophilia, but you're not 100% sure because the hints in the question aren't good enough, then it's very likely it's not hemophilia, simply because the patient is a female in the question. Right? So keep that in mind. So let's go over here. So normal hemostasis, we talked about this already, right? We broke it all down. We went through this diagram. We understand all of this, all the different parts that need calcium, your extrinsic, intrinsic, how the extrinsic indirectly activates intrinsic using thrombin activating a bunch of shit, and your cofactors 8 and 5. We talked about all of this. Make sure you're able to revise that to yourself. And then right here we have the elevated PT and or PTT. So you could do a 1-to-1 inhibitor mixing study. This is something that's CK related. You're going to have this as an answer choice, picking to do the mixing study. 1-to-1 inhibitor mixing study. If you do the mixing study, what is the mixing study? So that's described here. Mixing a patient's plasma, right? Mixing a patient's plasma is, so in mixing, a patient's plasma is mixed with normal plasma from a normal healthy individual who has every factor to help diagnose the coagulopathy. Normal plasma provides coagulation factors. Therefore, it corrects prolonged PTT in the setting of coagulation factor deficiency, but fails to correct prolonged PTT in the setting of a coagulation inhibitor. The most common coagulation inhibitor is lupus anticoagulant, a type of an antiphospholipid antibody. So what is happening here? So basically you're seeing that if a person has an elevation of PT or PTT, it usually means they're missing some kind of factor. More specifically, now that we have our mnemonics down, the WEPT mnemonic or the PIT mnemonic was telling you that if their PT is elevated, something was seen in the intrinsic thing, right? And the HTTP mnemonic for IHTTP, right? The PIT mnemonic, that one was telling you that if someone's PTT is elevated, that's an issue with the intrinsic, right? So extrinsic, intrinsic. You have your PET mnemonic, PT elevated, extrinsic is messed up. PITT mnemonic or HTTP internet mnemonic for your if your PTT is elevated, intrinsic issue. Either one of those things usually meant that some specific factor was missing, as we saw. However, if you do a mixing thing and you take some healthy person's plasma, and you put it into the sick person's plasma, it should fix it all because the healthy plasma would replace whatever the sick person is missing, right? But that won't work in a person who has lupus or some variant of lupus, any other disease that acts like lupus. I remember lupus is a common imitator of many other diseases that can also have similar issues. So when it doesn't correct it, when mixing with normal plasma doesn't correct the PT and PTT, that's when you know that this person doesn't have a lack of some kind of coagulation factor. This person has an inhibitor. Some inhibitor that is inhibiting even the normal guy's plasma from working. And then that's when you would pick whatever answer choice has some kind of inhibitor. One inhibitor we just learned about here is lupus anticoagulant, which is an anticoagulant and inhibits the coagulation factors from working together. Other inhibitors could be like heparin, warfarin, or some other fake thing a question might make up as a scientific experiment kind of thing. So you got to be ready with that. Let's take a look at this question. So, a 32-year-old man comes to the emergency department due to a day of worsening pain and swelling in his right leg. He has no fever, chest pain, or shortness of breath. He was hospitalized 2 weeks ago for right lower extremity DVT after a minor sports injury. He was discharged on warfarin. Great. When he left the hospital, his INR was 2.2, which is good. So, this is something that you won't really, I don't think it's on the values thing on your test day either. You have to know that normal INR for someone who's taking warfarin is between 2 to 3. That's where you want to maintain it. The patient has been taking warfarin daily. Good. However, due to a busy work schedule, his dietary intake has been variable, and last week he missed his clinic appointment for anticoagulation monitoring. Very, very bad. Right? This could be fatal. So when I was doing my hematology oncology rotation, I had to tell patients, like, if you don't come in on your appointment, you need to call. You need to call. You need to call, and you need to schedule an appointment immediately. And we'll have to tie you in the next day. Even if the next day's appointments are already full, we'll have to get this patient to come in as an emergency thing because them missing their appointment could be fatal. And maybe their INR isn't in therapeutic range anymore. They might be having warfarin toxicity or warfarin ineffectivity. These things can kill them. He has no other medical problems. Blood pressure is fine. Right? Pulse is fine. Respiratory rate is okay. Exam shows moderate pretibial edema in the right leg. Today, his INR is 1.3. So now it looks like he's not taking warfarin. This is not within the warfarin range. Remember that normal INR is 1. That's basically anyone who has all their coagulation cascades and is not taking any anticoagulation medications, nor do they have any disease that causes anticoagulation. So that's basically all of us, for the most part. But when you're taking warfarin, which is an anticoagulant, it makes your INR bigger. Right? So it's supposed to be between 2 to 3, not too big. This guy's at 1.3, so he's becoming more coagulable now. Platelet count, creatinine, and liver function tests are within normal limits. Venous Doppler ultrasound. So now the question is teaching you that when someone shows up like this, right, shows up with pretibial edema in the right leg, in this kind of a question, with worsening pain and swelling in his right leg today, right, then what do? You order a venous Doppler ultrasound. The question is teaching you that. So they ordered it, and what did they see? They see a right popliteal vein thrombus that extends into the femoral vein and is worse than on the previous ultrasound. What is the best next step in his management? Replace the warfarin with rivaroxaban. That was the correct answer choice. 40% of people picked it. But 25% of people chose this answer choice of placing an IVC filter. And another 20% of people chose initiate thrombolytic therapy, while the last 10% of people chose increase warfarin dose and follow up in 3 days. Now, having done my rotation, I knew this one didn't make sense at all. First of all, it's very hard to get people to come back in 3 days. Like, who has time for that, right? And then to increase the warfarin dose doesn't make sense either, because his INR is no longer in therapeutic range. He's unable to really take warfarin very well, as we could tell from the fact that his INR is not good. So giving him warfarin once again won't fix this. What if he doesn't take it? This patient was fine until his schedule got in the way, and now his DVT has progressed in the setting of a subtherapeutic INR. He needs immediate anticoagulation because of the risk of a pulmonary embolism. Oral direct factor Xa inhibitors are as effective as warfarin in the treatment of acute DVTs or pulmonary embolisms, and do not increase the risk of bleeding complications. These drugs have a rapid onset of action, no requirement for lab monitoring, and no requirement for overlap therapy with heparin, like a heparin bridge, which is only really a thing you need to do for warfarin therapy. Just avoid their use in patients with renal impairment or any kind of cancer, right, malignancy. An IVC filter placement is only needed when anticoagulation fails, but he doesn't have anticoagulation failure or contraindication. He simply doesn't have time to take his medications correctly. And that's understandable. He's a young man. He's probably got a lot going on in life. It's not easy to take some medication every day perfectly, right? Especially if his work schedule is getting that much more busy. Thrombolytics, which was the other answer choice, initiate thrombolytic therapy. Thrombolytics are for hemodynamically unstable patients with a pulmonary embolism. He's hemodynamically stable. Blood pressure's fine. Everything's fine. He just has that one thrombosis in the right leg. So going back to pharmacology here. So let me save this page real quick. Let's look at our factor Xa inhibitors, right? That's the thing they just gave. So the factor Xa inhibitors are nicely named because they have XA in the name. Apixaban, rivaroxaban are both Xa inhibitors. They are treatment and prophylaxis for DVT and PEs. Stroke prophylaxis in patients with atrial fibrillation. Oral agents do not require coagulation monitoring. You just give it to them and they go home. Okay, that's it. This is a very good question to teach a very important concept of something that basically happens very realistically. We're talking about medications, so we'll keep talking about them as we're talking about them. Here in the CK book, they really just list it out and they don't really teach too much about it because they've already assumed you're learning all this in the Step 1 book, and you are. Next thing, hemophilia. So we just talked about the fact that all hemophilias are X-linked, which is why they're going to pop up in men. Now, can hemophilia occur in a female? Of course it can. But then that would require 2 really bad selfish parents. Because if you're a man who has hemophilia and your wife or the girl you love or whatever also carries the gene for hemophilia, you two should not be getting married. That's very selfish. You're going to give birth to a child who's going to have hemophilia. And that's pretty fucked up. Why would you do that to your child? Right? It's just pointless. Same thing with sickle cells. And the other thing I used to do in this hematology rotation was that, as you can imagine, so I did this rotation in Atlanta. As you can imagine, most patients that came in to the clinic with their blood disorders were all black. I actually can't recall right now at all if I ever had a white patient in that clinic. And that's because these, I don't know what the reason is for it, but these blood disorders, and of course we all know sickle cell is more common in African Americans, but even the hemophilias and stuff, as far as this clinic's dynamics were concerned, were more common in black individuals. So when these patients come in and they, especially more importantly the sickle cell patients, when they come in and they tell you that they found someone they want to date. Now, the sickle cell patients and my doctor, Dr. Anthony Onyebula, were very close to each other. Like every patient was like family, because sickle cell is a lifelong treatment and you see the patient go through their worst days of their life. Like I had patients who had sickle cell and they had the clumping up of red blood cells in their penis causing extreme pain. Right? Extreme pain. That's one of the many kinds of pains you can get in sickle cell, right? The sickle cell crisis, where those red blood cells clump up in various capillaries anywhere in the body, leading to tons of pain. So when these patients came in telling you that they found someone, you tell the patient to bring in their boyfriend or girlfriend and test them to see if they have any of these blood disorders, to then advise the patient that you might want to find someone else. Right? A sickle cell carrier person shouldn't be marrying another person who's a sickle cell carrier, because now you're going to give birth to kids who have sickle cell. Part of the reason sickle cell is still actually there is because there are people who have sickle cell who continue to marry other people who have sickle cell trait. Right? That's really stupid, because I understand that you might love each other, but then you're doing something extremely selfish where you're already not loving the child you might have in the future. And that's what they really need to consider. Same thing here as well. So if a person who has hemophilia marries another person who might have or carry hemophilia genes, is just being selfish. So that's why it's very, very unlikely for a woman to get hemophilia. Both parents would have to have the trait. But a man can easily get it, because the woman might be carrying the trait and the husband might not have hemophilia at all, nothing, but the woman will give her X off, right? And then that would go to all the sons. All the sons get the X chromosome from their mom, and they get the Y chromosome from the dad, right? So then the mom will pass it on to the kids. And that's why it's very important to get testing done to see if you are carrying hemophilia or sickle cell genes, especially if someone in your family had it before. But as far as STEP is concerned, all your hemophilia questions, as you can already see here, this is probably a hemophilia question if I wrote it here, are going to be for boys. Right? So what are you going to see in them? Delayed prolonged bleeding after mild trauma, hemarthrosis, which is probably what's happening in this question, hematoma, yeah. Hemarthrosis, so arth usually means in bones, right? So this is going to be bleeding in like the knees and stuff. Intramuscular hematomas, gastrointestinal and genitourinary tract bleeding, and even intracranial hemorrhage. Complications could be hemophilic arthropathy, right, which is pretty bad. You're going to be a really young person with really bad symptoms similar to arthritis. You're going to note elevated PTT. Why? Well, remember the things that are missing in them, right? Hemophilia was mainly, A was for 8 and B was for 9. 8 and 9 are both here in the intrinsic pathway. Right, this is your 9. The 8 was the cofactor. So these guys are not going to be there, so this is going to get messed up. PITT, right? Remember? PITT, right? Or HTTP internet for the HTTP. Either one reminds you that this is all going to affect your patient's PTT. So their PTT will be high, but normal platelet count, so they won't have any thrombocytopenia, and normal PT, because their factor 7 is good. There's going to be an absent or decreasing factor, whichever one, depending on which hemophilia they have. And how do you treat it? Just give them the factor they're missing. You can also use desmopressin for mild hemophilia A. This is a tricky answer choice. Most people don't tend to remember the fact that desmopressin actually will cause, they don't have the blood vessel here, but remember how I showed you in the step 1 book that von Willebrand factor was in your endothelium? So desmopressin is going to constrict the endothelium, causing von Willebrand factor to come out of the endothelium, and it'll bring factor 8 with it. So someone who has mild hemophilia A is mildly missing factor 8, you can just give them desmopressin, and they'll release the von Willebrand factor. So that's what this answer choice is here. Clotting factor deficiency. So we already looked at all of this. We understand this concept. Presents as a young boy. So you see, they tell you here, because girls are very, as far as STEP is concerned, it's pretty impossible for a girl to get it. Presents as a young boy with spontaneous bleeding into the tissues, muscles, and joints that, if untreated, can lead to crippling arthropathy and joint destruction caused by the hemosiderin deposition and fibrosis. Right? A 5-year-old boy is brought to the emergency department by his mom's boyfriend for evaluation of thigh pain. This morning, the patient bumped into the edge of the table in the living room and now has swelling and pain in the right thigh. The way this question started off, it really reeks of potential for a question about child abuse. Right? Why would a 5-year-old boy be brought in by the mom's boyfriend, right, which is a very likely person to abuse the 5-year-old? Although in reality, it's not that common. In reality, it's the other way around. For some reason, in reality, it's the females that are going to be the child abuse person. So it's going to be some woman, either the caretaker or babysitter or the girlfriend. Men don't really tend to be doing this statistically as it's seen. So, as you're reading this question, you stay on high alert to see if this is a question about child abuse. That did the kid actually hit his, the knee? The thigh, right? Hit his thigh onto a table, or did you beat the child? Okay. Family history is significant for a maternal uncle who died after developing intracranial hemorrhages from a minor head injury last year. Boom, right there already it sounds a lot like hemophilia. Examination shows an uncomfortable appearing boy with marked ecchymoses and swelling over the right quadriceps, his right thigh. What will most likely be found on further history and examination of this patient? Episodes of joint pain with swelling, because this is something that's been happening to him since he was born. His hematoma after minor trauma and family history with bleeding disorder in a maternal uncle are concerning for hemophilia. Always the maternal uncle, by the way. If the question tells you about a paternal uncle, that's not good enough. Maternal uncle, because mom is the one that gave him the X chromosome that had hemophilia on it. Right? Dad doesn't give a son an X chromosome. Dad only passes on Y chromosomes to all his sons. Right? And X chromosomes from dad go only to the daughter. Okay? So maternal uncle is key. The most common signs of bleeding are the joints, especially the knee. Hemarthrosis presents with joint pain and swelling after minimal or no trauma. And episodes typically begin during toddlerhood when the child is ambulatory, when the child can finally start moving on his own, which means he could fall a lot. And then, you look for those things. Spontaneous intracerebral, renal, retroperitoneal, and GI hemorrhages are also seen. Mild cases may have major hemorrhage after surgery, trauma, or dental procedures, but are otherwise asymptomatic. So this is another presentation for a question, right? Someone who just came to America from another country where they might not have gotten tested for PTT, PT elevations and see if maybe they have a bleeding disorder. And now today they're here for their first tooth removal or something, and they won't stop bleeding. That's your giveaway that they had some kind of bleeding disorder, maybe hemophilia, maybe von Willebrand. You have to check, right? If bleeding is severe, diagnosis. So of course you're going to get questions on how do you diagnose, and then the next question is going to be what's the next best step in management, right? Those are your CK questions right here. Step 1 questions were about all these things. CK questions are about diagnosis and treatment. So PTT is going to be prolonged. Factor 5, 6, 7, 8, 9, and 10 are all intrinsic pathway on basic bleeding workup. PT and bleeding time will be normal. Best initial test is to do the mixing study, like we just talked about. Right? That if this is a person who's mixing, maybe this person is missing factor 8. So if I take plasma from a normal, healthy individual and mix it into his plasma, it should correct the PTT elevation because now there's factor 8 coming from the normal plasma. Mixing study. Mixing the patient's plasma with normal plasma will correct the PTT because you replenished the mixing factor. Right? It will not help someone who has an inhibitor in their factor, though. Inhibitor in their plasma. The most accurate test to do, obtain specific factor assays for factor 7, 8, 9, 10, and 12. Sorry, wait, what did they 7, 8, 9, 11, and 12, not 10. Right? 7, 8, 9, 11, and 12, just to check where the problem is. But you're really just picking things that are part of mainly the PTT pathway, intrinsic pathway. Because remember, extrinsic was really easy. It was just factor 7. There's nothing else there. If bleeding is severe or factor level is less than 1% of normal, which is extremely severe, extremely severe deficiency of whatever factor, immediately transfuse the missing factor. Or, if unavailable, use cryoprecipitate. So what is that? So here they tell you, cryoprecipitate consists mainly of factor 8 and fibrinogen, with smaller concentrations of factors 13, volume factor, and fibronectin. It is a more concentrated source of factor 8 and fibrinogen than fresh frozen plasma. So you're going to have both answer choices there. But fresh frozen plasma was the better answer choice for quickly reversing warfarin toxicity. Right? Cryoprecipitate is the answer for helping people who have hemophilia. Right? It has the factors they would need. If bleeding is not severe and the factor level is more than 5%, hemophilia may be treated with desmopressin, which releases factor 8 from endothelial cells. Genetic counseling may be required, which is a big thing. That's what I was talking about with patients that came in telling you that they found a partner. Prophylactic application of clotting factor concentrates is the basis of modern treatment of severe hemophilia A. Right, so as soon as you know someone has hemophilia A, you prophylactically start giving them clotting factors before they end up developing any of these issues that can lead to crippling arthropathies. You don't want them to develop any issues their entire life. But the counseling thing is big, right? Because now with ethics becoming more prominent in STEP, you're going to hear about this. So this is a good experience for me to share. So when a patient came in and they had hemophilia, part of their today's visit was also, have you found someone you're dating now? You know, usually you don't ask this to a patient, right? It's not really part of routine visits, but in the hematology department, when a patient came in and they have hemophilia or sickle cell, you ask them, have you found a romantic partner? You know, is there someone you might, and they're going to have to tell you, they already know from the doctor's already given them the whole breakdown that if you find someone that you want to marry or potentially pursue a future with, that we need to do genetic counseling to check if they carry genes that can lead to kids who are going to have these issues too. Right, very critical thing to do. Next thing here, von Willebrand disease. So this one is autosomal dominant, and almost all questions on STEP are going to be about girls to help you differentiate from hemophilia. Right, this is just a person who has deficiency in von Willebrand factor, and because they lost VWF, they also have a deficiency in level 8, factor 8, which is actually carried and protected by VWF. The three main roles of VWF are to bring platelets to exposed subendothelium, aggregate platelets to each other, and bind to factor 8. Symptoms are caused by platelet dysfunction and deficient factor 8, but are milder symptoms than hemophilia, because they're still going to have factor 8 that's being made in the liver, right? Factor 8 is still going to come, just not that much of it. Von Willebrand disease is the most common inherited bleeding disorder, 1% of the entire population. And the most common form of von Willebrand disease is type 1 von Willebrand disease, which is mild to moderate deficiency of von Willebrand factor. Type 2 includes qualitative defects in their von Willebrand factor, and type 3 is an absence of functional von Willebrand factor. Will you have to know the difference between type 1, 2, and 3? Probably not, but I can't really tell you. I don't know. It's very unlikely you're going to get a question where you have to pick between type 1, 2, or 3. In step 1, they didn't even mention that there is a type 1, 2, or 3. It was just von Willebrand disease. Where, of course, your platelet count is fine, so there's no thrombocytopenia. Bleeding time is elevated because you're missing factor 8. PT is perfectly fine because PT is, PT is your PET mnemonic, which is for the extrinsic pathway, which is factor 7 only. Factor 7 is not affected, right? PTT is high in most patients. It could be normal too, but it's probably going to be a little elevated. Just not super elevated because PTT is your IHTTP, which is for your intrinsic pathway with heparin and all that stuff, PTT, right? Intrinsic involved all the other guys, 2, 7, 8, 9, 10, even 5, a bunch of other guys, right? So you have to make sure you, well, 10 is common, but yeah. So this is going to be a very important thing to remember. And you could try treating this with desmopressin to release von Willebrand factor from the endothelium. But again, now when you come to CK, you can see how, you know, if type 2 has qualitative defects in von Willebrand factor, then giving desmopressin won't help, because you're still going to release defective von Willebrand factor. Same thing with type 3. Giving type 3 people desmopressin won't help because they're just going to release bad function von Willebrand factor. So if your von Willebrand factor itself just sucks, desmopressin can't help. But if you have type 1, which is the most common, where you just have a deficiency of von Willebrand factor, then you can give them desmopressin and they'll release more von Willebrand factor. Alright, so that's something that they're kind of making harder in CK. Often presents in childhood with recurrent and prolonged mucosal bleeding. Right, so a very key thing to watch out for. In hemophilia, we saw bleeding within bones, hemarthrosis in the knee, in the thigh, in intramuscular, right? Big hematomas everywhere. Here we're seeing bleeding in the mucosal areas, epistaxis, bleeding from the nose, gums, gingival, menorrhagia, too much bleeding in the menstrual cycle. Right, so this is why I'm saying that you're definitely going to get a question on, if you get a question on VWD, it's going to be a 1. Right? And bleeding after dental or surgical procedures, which is mimicked in hemophilia as well. Often a family history is present. Symptoms worsen if you give them aspirin, which actually gets rid of even the platelets they would have. Right? Remember that part of the reason von Willebrand factor is even maintained is because they have aspirin. Sorry, what am I saying? It's because they have platelets. Right? They have platelets and they have this. The only thing they don't have is this. They're missing the von Willebrand, which makes them miss factor 8. All those things are missing. But they have platelets, so that can somehow maintain primary hemostasis. Right? If you're a person who has von Willebrand disease and you take aspirin, you just got rid of your platelets too, which is further going to worsen the whole hemostasis aspect of things. Okay, so that might be something they might put into question. So now here comes diagnosis and next step in management. Diagnosis, you could do the ristocetin cofactor assay. Right? It measures the capacity of von Willebrand factor to agglutinate platelets and detects von Willebrand factor dysfunction. Right? We talked about the ristocetin assay just a while ago, where it completely fails in anyone who doesn't have GP1B or doesn't have von Willebrand factor. So if this person has no von Willebrand factor at all, when you give them ristocetin, it's not going to do anything. That's going to be a problem. Von Willebrand factor antigen level. Right? Decreased levels of antigen may be present. And initial bleeding workup will show an increased bleeding time in all the von Willebrand types, 1, 2, or 3. Elevated PTT, as in hemophilia, may be seen because of the lack of factor 8. PT and platelet count will be normal. So how do you treat it? Desmopressin will work for type 1, mild to moderate disease, where you just have a deficiency of von Willebrand factor. Use factor 7 replacement or von Willebrand factor concentrate for severe disease that does not respond to desmopressin, or for major bleeds and surgery. Control the menorrhagia with oral contraceptive pills, and avoid aspirin, NSAIDs, and platelet function inhibitors, because you need your platelets when you have a deficiency in coagulation factors. Your platelets become more important because they're the only thing allowing hemostasis in them all the time, primary hemostasis. All right. So right here they talk about the ristocetin thing. Decreased agglutination seen on the ristocetin cofactor assay in von Willebrand factor dysfunction, right? As well as in your GP1B issue, which was your Bernard-Soulier disease. All right. Von Willebrand types 1 and 2 are generally inherited autosomal dominant. Type 3 is inherited autosomal recessive. Again, not something that you need to worry about too much. Just know there are multiple types, and type 1 is the most common, which is the one that you're just having a deficiency of von Willebrand. Type 2 and 3 are the ones that your von Willebrand just sucks. You make a little bit, but it's just so bad that it can't do its job. All right. So that's basically it for all of that. Here, your hypercoagulable states. So your hypercoagulable states, there's a couple. Right? There's a couple places, a couple issues that can lead to hypercoagulation. And we talked about HIT. Let me see what else there is here. Let me just... Causes of hypercoagulable states. So they've really just only listed it out, it seems. Are they actually talking about it somewhere? Let me see. This DIC is a hypercoagulable state, but then the rest is just TTP and ITP, right? And that's it. So they're not actually talking about it. This is going to be very... Okay, so this is why you go back to step 1, because in step 1, first aid, they have these topics. They have all of these topics nicely mentioned, right? So we will have to go back and revise from there. So yeah, we will stop here for now. That was a really good revision of everything we did from step 1. Good revision of the coagulation cascade and primary hematology. and primary hemostasis, and then next time we'll wrap up the rest of these coagulation disorders. All right, thanks a lot for joining, guys, and enjoy your night.